Hello, my name is Jill Earwood. I'm a Safe Patient Handling and Mobility Coordinator at the Western North Carolina VA system. I'm going to present SPHM Island Marking the Days and share with you some best tools for tracking and monitoring our program success and progress. We have a few objectives during this session to describe the importance of program evaluation, identify trends in data and potential responses to trends, and list 4 positive patient outcomes when we integrate SPHM into patient care. So let's just cover a few things about marking the days on this island we're on. Well, I think we all just want to make it home. Plan the journey, set our course, be sure of our way, and know that we're going to find treasures on this voyage and arrive safe at last, finally. So why take the journey? Well, program evaluation is necessary so that we can improve quality, defend our program and the value of our program, guide our future, and disseminate the results so others can celebrate with us and take part in implementing change that's positive for both our caregivers and our patients. Another reason why we should take this journey is because it is based on evidence and supported by the ANA. So the ANA has interprofessional standards that recommend that there is a program established for safe patient handling and mobility and that it is evaluated throughout planning and implementation. And we have specific goals that are set as well. I provided a link to ANA in the PowerPoint presentation for you to access if you need to. We also want to take this journey because our own system in the VA, which you may not be in the VA, but know that VA is ahead of the mark a lot of times when it comes to SPHM. And we have guidance for how we should evaluate our program and why we should have programs for SPHM. You can find this guidebook on a public site, and I listed that link here for you in our presentation. Some other reasons about this journey, why we should take this journey. OSHA has a statement and a position on SPHM programs, and that we should have these programs in place, and that we want to reduce our musculoskeletal disorders by implementing SPHM programs and evaluating those programs over time. The Joint Commission also has a position statement about SPHM, and they actually highlight the VA in the process. TJC says staff and hospitals aren't the only ones who can benefit from an effective program, that patients alike benefit, and we're going to talk about that further in the presentation. The Joint Commission states that research shows the quality of patient care improves when we implement our programs, and they also partner with OSHA to state that we can have actual decreased falls and skin tears and pressure injuries, and also decrease cost and increase satisfaction scores. So this is just a schematic to show how our programs benefit our caregivers and our patients alike. You can see that compliance with an established SPHM program has impact far beyond what you might think, even to the length of stay, even to the cost that's spent on patient injuries and staff injuries. There's just so much impact that your program can have on their hospital system. So we've talked about why take the journey, why have an SPHM program, why evaluate that program. The next step is set our course. We want to make it home. So how do we set that course? Well, when we make it home safely and we have beautiful outcomes from our journey, we have to report. We have to know what to report, how to report, and evidence-based tools for that. The first thing you want to ask yourself about reporting is, what do I want from it? Well, I want to tell management what we need for our program. You can't have a program without the support of those key stakeholders. So you want to engage them by sharing information. Sell the value of what you're doing. Sell your outcomes. And compare yourself, if you're able to, with other facilities so that you can demonstrate the success in comparison and benchmarking. And then also your reports force you to look at your program, take a hard look and figure out where you might need to concentrate. Find that low-hanging fruit and tackle that first. You also need to make sure you know exactly who you're reporting to. Have a structure. A facility committee that oversees is super important so that you have some accountability and you also have you're visible. You want to engage with key stakeholders, and I've said that before, but the one key stakeholder that you want to make sure you're getting time with is the chief nursing officer. We know that handling of patients is happening across settings, but nursing staff are definitely most impacted by manual handling. And we want to make sure we have the ear of the chief nursing officer. They can lend a lot of help. And then you also want to make sure that those unit level champions, which we call in the VA unit peer leaders or UPLs, that they're in the know, that you're sharing your programmatic outcomes and the work you're doing with them, not just expecting something from them. So additional ideas and advice for setting the course for reporting is to evaluate the committee. Is the committee working? Plan what you need from each person on the committee. If your committee is not working for you, you got to work on some relationship building, and you want to sell the value again of the program. Some sites actually use other committees, not an SPHM committee, to report. They have other committees that have those key stakeholders already on them, and that's fine as long as you're a part of that committee, a voting member, and you have a schedule to report, like an environment of care committee. Chief nurses obviously need to hear from us. I've said that before, and we want to make sure you're on a routine schedule with that chief nurse. Get that audience with them. And then what about the UPLs? What do you want to share with them? Well, you want to share with them what you would share with the committee: injury trends, the patient outcomes related to the program, issues and needs, and then the plans for expansion. There are some other committees that you might want to be a part of. You may not formally report to or on, but you want to make sure that you're getting the audience of those committees and also having a chance to speak up about SPHM and how it relates to their committee work. So accident review board, which or injury board, where you're actually talking about staff injuries, patient safety committees, so that you're hearing from and able to contribute to either decreasing the risk to patients or knowing about incidences related to manual handling or use of lifts. Being a part of the falls collaboratives or committees would be important because our equipment offers solutions for fall mitigation. Our facility safety committee, so that you're a part of construction design. There's construction safety committees, environment of care, your equipment and products committees. You definitely want to be a part of those so that you have input on what's being purchased and what decisions are being made. And then finally, sort of the practice side of the house, the nursing councils or other work groups, and any other discipline work groups that you can get on to make sure that you are keeping SPHM at the forefront of your stakeholders' minds. So, knowing your way, what are the report elements that you need to include? Well, obviously, we need to make sure that we're evaluating and reporting on employee injuries and looking at trends. Also, patient incidences and near misses. Those are the near misses are just the gold in our reports because we didn't have an event, but we almost did. And evaluating the factors around that knowledge is invaluable. And then the next thing you want to make sure you include is what are you doing about the trends? So what are you doing to prevent future injuries and how are you addressing trends? And then ultimately you want to be circling back after you report to report on the progress of your actions. So one report, you will have the injuries, and then the next time you report, you want to follow back up on those injuries, not just report new injuries. Additional required elements of reports include your new equipment projections, your ergonomic updates and evaluations, your training of your UPLs, of your staff, any process or policy changes that you've implemented. For instance, if you have some new issue come up, like maybe it's car extraction for routine appointments and you come up with a new process, you want to make sure that that is included in your reporting to your oversight committee and to your UPLs and anyone else that you would see as a stakeholder. And then finally, patient outcomes related to the use of SPHM and in, for instance, early mobility programs. Now, we talked about how we report and knowing our way. Now let's talk about finding the treasure. Where are we going to look so that we can see the results of our hard work? Well, the methods of getting incident and near miss data might vary according to what system you work in, what facility you work in. So, but what doesn't vary is the importance of relationship building. So you have to build relationships with those who hold the data, like safety office, your workers' compensation, employee health staff. And then for patient incidences, your patient safety officer, your direct care staff, your quality management staff. You want to get access to your facility databases so that you can look at the data, go find and dig for yourself. So you want to know where your employee injuries, that information is kept so you can see it. And you also want to know where your patient outcome reporting systems, where those databases are housed, and get access to those databases. When you're reporting, you want to make sure that you're looking at data over time and trends over time using a rate format so that you aren't simply looking at raw numbers for both your caregiver injuries and your patient outcomes. Rates make data consistent over time despite our staffing and patient census fluctuations. Rates make data comparable. Raw numbers might fool you, and denominators matter. For example, when you're looking at data over time, you're looking at employee injuries, the productive hours worked, the number of hours that people are working is important to use. But when we start comparing patient data to our staff data, or we're looking at patient data, we're going to be looking at the actual patient time at the facility, like their bed days of care, the number of visits if it's in a clinic setting, the minutes of care if it's in, for instance, the ED or PACU. And then also you might be looking at nursing hours to compare injuries, to compare patient outcomes. The reason it's so important to really dig into the data and make sure you're using rates is because you also might want to compare yourself externally from your facility to some other place, some other facility, some other organization. And by using the same denominator as the other organization, but using a rate allows you to compare yourself to smaller or larger institutions. So for figuring out your staff injury rates, the VA uses the hours of work as the denominator, looking at that trend over time. And you can see our formula here. It's the number of incidents over the number of hours worked. And then you multiply that by 20 million to get a rate of injuries per 10,000 full-time employee equivalent. Lost and restricted workdays also indicate severity, so it's important to look at those rates as well. You might have an increase in injuries as your program ramps up, but you might have less lost and restricted days, which indicates that you have less severe injuries occurring. OSHA uses a similar formula. The multiplier is actually 200,000 rather than 20 million, so the rate is per 100 FTEE. It doesn't matter what you use as long as you use the same denominator and multiplier to compare over time. This next slide is just giving you a visual of comparing raw numbers versus rates. You can see they follow the same trajectory, but if you look at the individual years, you can see that sometimes the raw numbers will make you think your program is performing better or worse than the rates. Here is a visual for how you can display your injury rates. The top graph is the employee patient handling injury rate over time. The second is the actual DOL claims rate, so that severity piece of the DOL claims rate over time. This is just an example of how you can display. It's a quick visual. Leadership teams normally like their information concise and clear, and this makes it very easy to see how dramatically the injury rates and the DOL claims rates have decreased over time, over the years, as the SPHM program has implemented across the facility. Medical costs can be a great thing to report. Sometimes that can be challenging to obtain. If you're able to get medical costs related to specifically patient handling injuries, that would be great. In the VA, we're not able to tease out which of the costs are associated with just patient handling. But what we have done in some facilities is just look at the relationship between the medical costs for medical personnel injuries over time and compare that to the lifting repositioning injury rates. And you can see the red line is that medical personnel workman's comp cost, and the blue line is the injury rate for lifting and repositioning. And what this graph has a dual axis. So on the left, when you're looking at the screen on the left, that's actually the first axis, the primary axis, which is the employee injury rate. On the right-hand side is the secondary axis, which is the medical personnel costs. And you can see by putting them on the same graph that they follow the same trajectory, which as the SPHM program is implemented, the injury rates go down, and so does the facility workman's comp costs related to those medical personnel. Now, you want to take all of this information and dig. You want to look at your data, look at your outcomes, and start digging deeper. Because if you don't ask why, you might not get to the root cause of why your injury rates are increased overall or increased in a certain care area, or why they may be decreasing. So you want to know the why so that you can tell your stakeholders and you get more and more buy-in the more knowledge you impart to them. You always want to ask the question why. So look for the system causes of incidences. Is there availability and functionality of equipment? What's the culture and the influence? What's the knowledge base of the staff and the supervising staff? Look for reasons for changes. Why might your injury rates be going up? What's changed? Why might injury rates go down? And your injury rates might go down because your program is super successful. However, your injury rates can go down because people are afraid to report or it's difficult to report. You just can't take the data at face value. You have to be asking those questions. You want to look at nurse turnover. Like I said, we do handle patients across the care continuum, but the largest mover of patients would be our nursing staff. And our number one injured would be our nursing staff. So you want to look at reasons why nursing staff would be injured. There's a lot of turnover. You might have more turnover if there's lack of support for SPHM. Are they worn out? Nurses could be leaving because they're just injured, and we know that. You want to find out about that. You want to look at the nurse turnover in comparison to your injury data. And also, if you're able to get a hold of your employee surveys and satisfaction results. Absenteeism can also impact your injuries. If you're having more injuries or you're having non-compliance with using equipment, you might see increase in call-outs, even though you may not have the formal reporting. So you want to look at both. You want to look at, have the injuries gone up, have the call-outs gone up? But if you're on facility committees and you hear, well, call-outs are going up, well, start digging, see if that has anything to do with staff being injured that you may not even know about. And this might be, you might be looking at the global data, but you may need to be digging into the unit data. So maybe you have an outlier. So drill down to that unit level. Another idea for digging deeper into data is to find that treasure, to find what we can do to improve and how we can experience success, is to look at nursing hours, overtime, our injuries, and our patient outcomes. So globally, you look at this, but you also drill down, like I said in the previous slide, to that unit or section level if you see an outlier. Do you have less nursing hours? If no, but the bulk of the hours are provided by overtime, that's not a good situation. Do you have more overtime? And you want to compare both of these to your staff injuries, or increased injuries impacting staffing. And you want to also look at your patient outcomes. Or do you have increased falls and injuries and overtime? And are these impacted by either non-compliance with the program or are people not complying with the program because they're shortcutting, because they're overtired? So many contributing factors and competing factors when it comes to looking at your data. So ultimately, the goal here is to look for impact of injuries on nursing hours and/or increases in overtime, and impact of lower hours on those patient outcomes. So here's an example of how you can display the nursing hours data and the patient outcome data. And what you can see is that as the safe patient handling injury rate is decreasing, which is the red, we see and the nursing hours go up, we see the patient outcomes improve over time. Also, when you're trying to intervene at that unit level or that section level, you can use this example of how we in VA compared two different facilities, actually. You can compare two different units with the same method. You want to pick a unit that adopted and is SPHM and is high performing when it comes to compliance with SPHM, like low staff injuries, low patient falls. You know that culture's there. You know they're doing the right thing. And you can use that as an example to motivate other later adopters or lower performing units. So you can see on the graphic that the late adopters are in red, the early adopters are in blue. And you can see the difference in those injuries, the injury rates over time as the early adopters progress with the program, and how they improved their injury rates, whereas the later adopters did not see the significant improvement that the early adopters did. So you can use this as a motivational tool with your managers, make it a competition, whatever, to just try to get those lower performing areas to come up to speed with SPHM. You can also dig into the culture of safety results. If your facility, most healthcare institutions evaluate culture of safety and safety with reporting, and you can compare it to your injury rates over time. When you look at this graphic, we compared two facilities, one who had an early adoption of SPHM and one who was lagging behind. And what you can see is that with the late adopter, which is the red line, and the early adopter, which is the blue line, that those in the early adopter category had higher scores on the culture of safety survey for those facilities in the domains of safety education and training provided to me to safely accomplish my job. And we're going to move on in finding this treasure along our voyage to enjoying the surplus. So we've talked about the staff impact, a little bit about the patient impact, but SPHM has so much to offer patients and to the improvement of patient outcomes. And we can report that data, and we can use that data to engage stakeholders to support our program and to fund our program. Report data to support positive patient outcomes from using the technology to mobilize, or to support the comfort of our patients. The following items could be used to report if mobilization is occurring using SPHM technology. We could use fall data, happy data, vent days, OMLOS, which is that observed minus expected length of stay, which most facilities look at. It's that it's the severity length of stay, and that number changes over time, of course, as we implement improvement efforts. So you'd have to always make sure that when you're reporting outcomes related to your program that impact patients, you want to make sure that you state that there are obviously competing programs and competing initiatives that can impact this data as well. But when you compare it with your staff lifting injuries over time and see the same trajectory, then you can safely say that you're impacting the patient outcomes as well. Another measure would be mortality, hyperglycemia, and healthcare acquired infection rates. You also want to tell stories, and we're going to cover some more of that further in this presentation. But pictures are good, stories are good, and it's all about the data, but it can also be all about the story. Some examples of patient outcomes I'm going to share in the next few slides. This slide shows a facility that implemented SPHM, and they also implemented a mobility screening tool, and they saw a reduction in falls. You can see the top graph, the red line is the patient fall rate, the blue line is the staff injury rate, and you can see that as they implemented SPHM and a screening tool that recommended equipment for patient movement, that they saw a decrease in falls in addition to their staff injuries. The second graph is also a patient outcome graph, which shows the rate of vent days in the ICU setting in this facility as they implemented early mobility programs in their ICUs using SPHM technology. And of note, their last ventilator-acquired pneumonia was in 2012. So you can see how SPHM greatly impacted patient outcomes at this facility. Another example is a facility that implemented early exercise and progressive mobility on their acute care units. So two ICUs and one post-op unit, a regular floor. And you can see pre-implementation, you can see the length of stay. This is an example of length of stay, the average length of stay for those units. And you can see pre-implementation for all three units, their average length of stay was higher than after they implemented EEPM in these settings. So the program proved successful in reducing the length of stay as they mobilized their patients safely, using the equipment, and more often. One more example of a facility success with EEPM using SPHM technology is there's several items here. You can see that the ICU average length of stay in this facility changed by -12, which is great, by 12%. The number of ventilator days decreased by 13%. The functional status at discharge, so patients returning to community independently, changed by almost 30%. So almost 30% more patients discharged to home rather than going to short stay rehab, long-term care, or some kind of assistive setting. The fall rate changed by nearly 37% in this pilot study, which is pretty phenomenal. And they only had one staff injury during this time frame. And so as you increase mobility in a lot of settings that don't use the SPHM technology, what you see is an increase in staff injuries related to that mobility. So the success was definitely noted here at this facility. Now, moving on to enjoying the surplus in telling stories and using pictures. Pictures are worth 1,000 words, and you just can't unsee things. So it's really important to use pictures and tell the story of your patients and your staff as you can. This example is a World War II veteran who was in the ICU, and he was intubated, and he had been intubated for several weeks. He had failed extubation a number of times. He would be weaned off the ventilator, and they would get him extubated, and within a matter of hours he would need to be reintubated. Whenever this ICU implemented EEPM, he was able to get up using a walking harness and a mobile lift and walk from his ICU room down the hallway. He still remained intubated, as you can see, and the staff were safe. He was safe, and the lift offloaded the weight so that he was actually able to bear some weight, but not full weight. But he was able to get moving. His outcome was pretty phenomenal. After several walks with this lift over several days, he extubated successfully, and within a short period of time was sent to short stay rehab, and within about 4 weeks was sent home. So that's a great outcome. Most people thought he would never make it home again. So this outcome is a beautiful story for how EEPM and SPHM together create positive outcomes for both staff and patients. Here's another example from another facility, and this this graphic shows how important it is for nursing and therapy and SPHM to partner together. So the story of this veteran is that he thought he would never make it home again. He came into the hospital, was there for quite some time, had not been up. He was very critically ill, and he progressed to the floor. And with therapy and nursing partnering, and the SPHM coordinator being that SME for the equipment, they were able to use a bariatric ambulation sling and a Denali lift and ambulate this gentleman. He was able to discharge from the hospital in a short period of time to short stay rehab and ultimately go home where he thought he would never return. And this success story is just another example of how our technology, married with stakeholder engagement, helps us to enjoy lots of surplus in our treasure along the way. The final story I want to share with you, the patient outcome, isn't about EEPM. It's another aspect of how our program can impact patients in a positive way. This veteran was at the Tennessee Valley VA, and his desire, when you have this PowerPoint presentation, you can actually click on the story from the Wall Street Journal that a physician wrote about this experience. This veteran was in the ICU. He had transitioned to comfort care and desired to be baptized. His words were, when he wrote them out for his daughter, were, "I want the full dunk." So he wasn't going to have it any other way. The physician who wrote the article writes about how he was so reluctant, and he was trying every way in the world to get the staff to just agree, the nursing staff to just agree to something much more simple, like not the full dunk baptism. And nurses, being who we are, we pushed, and got this gentleman his wish granted. So she brought in this pool. She partnered with Biomed. She partnered with the hemodialysis team, and they were able to use the machine for dialysis to warm the water. And you can see this gentleman was lifted from his space in his room to this tub or pool into warm water using a ceiling lift and a full body sling, repositioning sling. And he was able to get the full dunk. And we were able to honor his wish. And he passed knowing that we had done this for him. So this is an example of how using our technology to meet patients' wishes, to meet them where they are, we have such value to add when it comes to meeting their needs. We know that SPHM technology is used throughout recreation and getting people improved quality of life and mobility, and ultimately to even honor their last dying wish. So the final part of our journey home is our safe arrival. And safety is paramount in healthcare. And the VA, along with many other healthcare institutions, are on the HRO, or high reliability organization journey. You never really arrive at this, but you're always on the journey. And our safe arrival home will ultimately end when we retire, and we know that we can look back and say we implemented a program that impacted HRO. I'm going to actually read you this quote, and there's a link here for where this, from the AHRQ, that this quote comes from. But I think it's important to read it out loud and let you reflect on SPHM as you know it, and really think about how SPHM and your program and your involvement impacts HRO. High reliability organizations are organizations that operate in complex, high hazard domains for extended periods without serious accidents or catastrophic failures. So HRO doesn't equal no error, it just equals no harm. That is our goal when we're a part of an HRO. The concept of high reliability is attractive for healthcare. So HRO started not in healthcare. It started in the nuclear industry. It also started in the airline industry. And healthcare has just recently, over the last 10 years, begun to really adopt. HRO principles. So it's attractive to healthcare because we have complex operations, and our operations pose significant risk and even potentially catastrophic consequences when the system fails. Sometimes people interpret high reliability as meaning effective standardization of healthcare processes, which standardization is important. However, the principles of high reliability go far beyond standardizing. High reliability is better described as a condition of persistent mindfulness within an organization. High reliability organizations cultivate resilience by relentlessly prioritizing safety over other performance pressures. So think about SPHM. Think about what we have to offer and how we can impact outcomes at the facility and institutional level by giving staff and patients what they need for care to be delivered in a safe manner. And the safety should take precedence over it being in a hurry, over any other performance pressure. More on from the AHRQ is high reliability organizations use systems thinking to evaluate and design for safety, but are keenly aware that safety is an emergent rather than static property. New threats to safety continuously emerge. Uncertainty is endemic, and no two accidents are ever exactly alike. Thus, high reliability organizations work to create an environment in which potential problems are anticipated. Why do we have our equipment? Because we anticipate staff injury if we don't. Detect it early. So if we have an issue, we want to detect what's going on, hopefully before it happens, but early on to mitigate others. And virtually always responded to early enough to prevent catastrophic consequences. So that's where you are integral in your HRO, is making sure that you're on the units, you're asking the questions, you're investigating near misses, you're investigating injuries, and putting actions into place to mitigate catastrophes in the future. This mindset is supported by 5 characteristic ways of thinking. Preoccupation with failure. Let's think about SPHM and preoccupation with failure. How are we preoccupied with failure? Well, we're constantly looking at compliance. We're always engaging with our UPLs to make sure that they're present on their units, that they're changing the culture so that when patient handling opportunities present, we know what we're going to do. We know what we're going to use so that we don't fail the patient and the caregiver. A reluctance to simplify explanations for operations, successes, and failures. I covered a lot of this when I talked about digging deeper. Knowing the why, not just saying, well, the simple answer is we want to be reluctant to simplify. We want to dig to know the why. The next characteristic is sensitivity to operations, situational awareness. Knowing the culture on the unit, knowing what was happening around the event, looking at each patient fall in a way that asks, could there have been a piece of equipment? Could there have been a technology to mitigate this? How could I have impacted this as a coordinator by implementing, a new technique or a new piece of equipment? So knowing the operations on units, knowing the data, and knowing the why. Another key characteristic is that deference to frontline expertise, which I think in SPHM in the VA, we certainly have that because we have those unit level champions, unit peer leaders. If you want to know what's really going on in a unit with a trend that doesn't look great, you got to go to those staff. You got to ask the hard questions. And you got to make sure that UPLs that are on the unit are actually engaging and engaging with you. The last characteristic is commitment to resilience. So we know that we're going to be challenged with safety risks, but we are more and more resilient by having an implemented program that functions in a safe way and that you're definitely involved in, that you are always present, that you are always available. And when staff trust you and they trust the equipment, resiliency will come. And finally, we arrive safe at last. My 2-year-old granddaughter loves the Baby Shark song. And at the end of that Baby Shark song, they sing Safe at Last. So when you have a program that is focused on the staff and the patient outcomes, and you're involved and you're asking the why and you're implementing actions that are evidence-based and make sense, you will arrive safe at last. So in closing, I want to go back to the beginning in marking the days on our island. Our ultimate goal is to get home, to journey home. And we do that by setting a course, knowing our way, looking for the treasures along the way, and arriving safe at last. SPHM program implementation is so worth the journey. It takes a clear plan of action to guide the way. Successes come in many forms, but ultimately, SPHM creates safe care environments that align with best practices. Thank you so much. And if you have questions, I'm happy to answer those questions for you.